and it was the song. And I literally
the first MRI I had was in one of those really tiny tunnel ones, and they didn't give me anything. I didn't know what to expect. They didn't give me anything
and I was so nervous.
to not with focus, and then they asked me my eyes, and I am extremely flexible.
I was like such a scared little kid.
And so, yeah. So, like, I was like, I guess I was moving my legs because I was in there, like, trying not to have a panic attack, even though, like, they had given me, like, I don't know, some sort of sedative, so it did nothing. Like, I was just still, like, I was so... And like all of a sudden they're like, you need to stay still. I'm like, oh, and they didn't realize I was moving, but I guess.
Well, and like some of those drugs, that you just you relax so much you don't know you're moving.
Well, another thing though is like the prescription they gave me. This goes back like when I didn't really know like what I needed help like over certain things or whatever, but I was already on an anxiety medication like in my life that was similar to what they gave me, and it was the same dose, so it was like it didn't really do anything.
Well, and everybody builds up a tolerance.
Yeah.
Are you coming up with a name?
Yes. I'm sorry. I gotta leave my mask.
I'm still taking names too for my little skeleton in my room. My daughter wants to name him Skittles, but I don't know. Nicole, when you're done, we're gonna start.
I'm sorry.
No, you're okay, because I think everybody's back.
Oh, I miss those old school desks that push you back and put it all on top.
Okay, technical factors. Technical factors are something that you as an X-ray tech can control. You will learn these 3 terms more in depth with Sarah. No, just kidding. But you will start hearing the terms milliamperage or MA. You'll also hear mass, which is milliamperage per second. So that's putting milliamperage and exposure time together. You'll also hear the term KVP a lot, right? And each one of those, mass and KVP, do something different to help penetrate the patient and make the image, right? They each have a specific job, which again, you'll learn in your physics class. Manual and automatic exposure control, AEC systems are used to set the factors. AEC is our friend, but sometimes it can make us lazy. If you'll turn around and see on the upright bucket back there, see the little 3 chambers? The chambers, the 3 squares?
Oh.
Yeah. Those are, those correlate with the actual AEC within a digital detector. And a lot of times you don't want the outer 2 chambers set for like a chest x-ray. You'll see it on your control panel. I can point it out to those who have labs today and in another lab. But you don't want the 2 upper chambers set for a lateral, because where is the body supposed to be positioned? Right? In the center of the bucket, right? So you want that middle chamber highlighted. Now, on a PA chest, most of the chest is right up against the bucky, so you want the top 2 chambers highlighted. Okay? We as X-ray techs select specific factors after consulting a technical chart. I disagree with this next slide. Technical charts should be in every room and on any mobile machine. I don't know if I can remember if there's any of these anywhere in my X-ray department in Kansas City. Does not mean that they're not accessible to you, because a lot of times most hospitals, sorry, my first place, have a version of this somewhere hidden or in plain sight of Merrill's, right? Because we never stopped using this. We're not looking up at there are technical factors in these books, right, that kind of help as a guide. So seek out, there might be older versions, there might be things in there you don't even need to know, but seek out the Merrills. They should have one at every hospital, every clinical site. But there are technical factors that you need to take into consideration. You can't really read that very well.
I know, I just tried to zoom out and on my phone and it was, yeah, I couldn't.
But they're out there. They should be in your book as well. Primary factors must be taken into account to establish correct foundation technique for each unit. Keeping in mind all of these things, the mass, the KVP, the AEC on the detector, SID. I'm gonna jump back real quick. You guys seen this yet? Did Nicole pull this out your first semester?
No.
Torture chamber? I'm gonna find a picture and show it to you guys. This is called a pigostat. Not very many places have it. However, Children's does. So, stick little baby in here. Little baby sitting like this. There's a strap, right? And it actually gives you the best chest x-ray you'll ever get on a small child. Because the detector goes back behind here, whether it's wireless DR or CR. Yes, ma'am?
Ma'am, you don't actually put a baby in
Yes, you do.
there. Really?
There's a little bicycle seat. Sit your little booty right there. Strap them in. I'll find you a picture of the pigostat. I'm not joking.
Okay.
The 2 times I've had to use them, I was by myself as a student tech at an outpatient clinic, and they had one of these things, and it worked. We do not have one in North Kansas City because it stopped working. Somebody broke it. But yeah, it was amazing. I got a really good chest x-ray all by myself.
How do you, if you don't mind me asking, how do you keep that baby calm? I
You
mean,
don't. They scream. They scream their head off. However, what can you do when a baby cries? What
You would think I would know because my baby's 12, but
What is a
I
baby
can't
doing?
remember.
I know, but
Oh,
it's
they're
been a long time for me.
breathing.
Holding their breath.
Yeah, they do that big.
Oh yeah, you blow in their face. I don't know.
No, but they tend to get so upset. For you that are not parents, right? Have not been exposed to small children. They get so upset that they go,
And then you take the picture.
"Wah!"
Oh,
and
yeah.
they take the picture. You can time a baby crying and screaming. It sounds horrible, but it's amazing.
I know that's
And the parents hate it.
Blow in their face.
The parents hate it. I've been there as a parent. My kids have had x-rays. And this, especially my oldest, before I got into this, I was like, what are you doing to my baby? But it's a necessary evil. Okay? Another thing I want to point out that we do have them here, sandbags. I mean, these suckers are heavy, but they're very useful, okay? As a immobilizing tool.
I was like, what are you doing with the child before you said blow in their face?
No, you blow in their face to get them to breathe if they're holding their breath. All right. You have to think about relative patient and part thickness. So you may not use a lot of technique for a hand, but you might use more for a thigh, right? Because why?
Not every patient
There's-
has the same thickness.
Right. Well, and like, think about a thickness of between children even, okay? I'll go back to this. A newborn baby that weighs 8 pounds versus a 2-year-old. Their part thickness is gonna be way different too.
There's more matter for the x-rays.
Yep. So I pointed out there's a grid and everything, whether it's a permanent grid, you can't take it out. CR and DR exposure indicators or other digital exposure value estimates. The IR are collimated field dimensions. I showed some of you yesterday how you can collimate the field of view, right? And then there's also the electrical supply characteristics, phasing, and frequency, which we'll get way in more depth with Sarah. We touched on a little bit of shielding yesterday. I'm not going to repeat all this. There are differences now in opinion on shielding. There are best practices in place as far as the standard goes. Some states may still require gonad shielding. It's kind of one of this weird up in the air thing in the past 2 years that's started to happen in our like it. I just went it down, if I shield, I'm just trying to protect the patient and it's not in the primary beam, right? So, a couple of examples. The picture on the left, you see the shadow shield? It's kind of hovering over the guy. But you're x-raying his abdomen, that could be in the primary beam, so I probably wouldn't use that. Then the patient in the middle, the two patients in the middle, again, it's still in the primary beam. So the patient might actually get more exposure because the beam's going around the lead. Now, the patient on the far right here, you're doing a chest x-ray on the table. You can shield their lower half, that's completely fine. That's not in the primary beam at all. Funny meme, when the hospital goes through budget cuts, I don't know how many times this has happened in the ER where nobody puts lead on for a trauma. You're the only one that walks into the room with the lead and the portable machine, and everybody stands behind you. IR placement. Again, I kind of touched on this a little bit in lab if you were in there with me. Your detector can either go lengthwise, crosswise, or kind of diagonal. We use diagonal a lot for tip fibs. So when you're dealing with the chest, a lot of techs will say landscape or portrait. Positioning named on IR related to the long axis of the body. So that's the relationship. Lengthwise placement most often used. I would agree with that. Central ray direction. The central ray or principal beam of the X-ray is termed the CR. So what is coming out of that X-ray tube is the CR. It's always centered to the IR. It's pointed towards the anatomy of interest. Unless the IR displacement is being used, unless you've got to angle it or something to change the look of a body part, it should always be centered to the IR or the cassette or detector. There's interchangeable words for IR, okay? General goal is for the central ray to be perpendicular to the part and the IR to minimize distortion, okay? The longer you go along in this program, you'll see what I mean by distortion. So if you put a dramatic angle on something, like a shoulder, that you're kind of having the patient lean over the detector, you can make that person's regular length arm look extremely short on an image because you've not quite matched the position of the IR to the central ray. The angle of the CR through the part of interest to avoid superimposition of structures. So there are times where you might angle it. It straightens out a curved structure. It aligns the CR through an angled joint space and avoid distortion of an angled structure, right? So there's certain parts in the body where we might have it off a little bit. I kind of showed, I can't remember which lab it was, how you would do an angled view into this part that looks like a lateral chest x-ray, but you're just angling here to get the TNC spine. Because this would be considered a curved part, right? It wasn't in your lab, okay. Source to image receptor distance, SID, okay? It's defined as the distance from the anode inside the x-ray tube to the IR. Do not confuse SID and SSD. They are two different things. This is a very good image to kind of memorize because it kind of tells you the difference. Critical technical components that it affects: magnification, spatial resolution, which is how pretty and clean the picture looks in quick terms, and patient dose, how much that patient is actually getting. A little bit more about SID. The longer the SID, it reduces magnification and increases spatial resolution. Okay, so that's why a chest X-ray is at 72. Because if it was any closer, it would actually make certain things in your chest, like your heart a lot of it is that's traditional. Some things have been moved to 48. Some of you in lab saw that on the equipment, right? Where you click in. 72 is the standard for chest x-rays and some other things. And it's to reduce the magnification. SID in Merrill's Atlas is specifically identified on the page of projections. You'll get to kind of know. Projection needed as far as distance. But it's, I guess they've just taken that table out and condensed it into the actual projections. Something specific, but we keep updating the book. If specific SID is not mentioned for image quality, a minimum of 40 should be used. The most SID you will ever use is 102, and that's for a scoliosis 6. And that's getting the whole entire spine. Source to skin distance. This is very, very important. Defined as the distance between the anode of the X-ray tube and to the patient's skin. Right? Affects the dose to the patient. It affects the dose to the patient. SSD does. It is recommended that the SSD shall not be less than 12 inches, so you can't go below 12 inches, and should not be less than 15 inches, right? So that's a little window. So this becomes a problem when you are x-raying obese patients, because sometimes you can't go any farther with your tube up from where the patient's skin is. Collimation of the radiation field. Your lab, great. You got to see this, right? I showed you kind of the difference on someone that's very slender build, how you can kind of collimate that field of view in a little bit more. You should always try to collimate on every patient. I just had a flashback to one of my teachers telling me that a long time ago. Try to collimate because it's not necessarily to keep it open for every patient, right? It's a bad habit to get into. This helps to minimize patient exposure. It reduces the scatter radiation, which in turn reduces the risk of adverse effects on contrast resolution. Again, clearing up the image itself that is produced from the X-ray going through the patient. It is a violation of ART to collimate larger than the required radiation field size. So there is a way on almost every machine where you can really open it up to larger than 14 by 17, which is a standard size. And you should not be doing that on every machine. Obviously there are certain cases, but you should not be doing it. Again, this is just an example of collimation. The picture on the left, they did not collimate. That is fully open. The patient on the right, or the picture on the right, picture B, that's collimated. This is for a shoulder x-ray. You should manually adjust the collimator to the appropriate body part. Shuttering is used for image display aesthetics only in DR systems. I wish I could give you a really good example of shuttering. It's like a cropping factor in photos, okay? Shuttering helps to not have a lot of white around a digital image. It brings in a little bit of resolution digitally on a computer monitor, but it does not take the place of collimating, right? So you can crop things, but when you crop things, you could be cropping something out that if the doctor needs to see it, it could be missed, okay? RTs are often tempted to use a larger than necessary exposure field than shuttering or cropping, right? This should not take the place of that collimation. And it gives the appearance that you've collimated, right? So if you're trying to use that when you're testing out in the hospital, most techs will catch you. Make sure you collimate. Even if you just collimate ever so slightly, you're collimating, okay? It creates a legal and ethical liability issue. If the cropped image information causes a misdiagnosis, the RT may be liable, right? Yes, ma'am.
Ms. Roseanne, how did you say you would deal with a patient who's obese when you're doing the source discount?
Get into that.
Okay,
There's,
sorry.
nope, you're good. Good question. Good question. Markers. We touched on this a little bit in lab. If you were in lab, you guys heard about your markers? I think Nicole told some of you were gonna have to get your own markers.
Yeah, that's what I asked Nicole. She said, yeah, you had, just don't, because I asked her, she said you don't buy the expensive ones because you lose them.
Amazon has really cool
Yeah.
ones.
they have
Etsy,
really
I'll give
cool-
you a.
I was about to say Etsy.
I
has
said
really cool
Etsy has
ones.
really cool ones because we have to get our initials put on them.
Yes, and some sites may require BBs. And I'll tell you that in a minute.
Sorry.
So these are permanent markers on this machine, right? You can just flip it. There's a left, there's a right, inspiration, expiration, upwards, right? If the patient's truly upright. These are just an example of a lead marker, right? Your markers will be like that, but you'll have them to take on and off of patients. Again, they should have your initials on them. You have to have a left and a right. You will lose a marker. R.I.P. But that's why it's good to have backups, and that's why Nicole tells you not to buy the expensive ones. Start cheap, then you can get fancy. I have a pattern on mine that I bought off of Etsy. It has like a Mexican blanket pattern. It's really pretty bright. I can see it. I know that's my marker. It doesn't blend in with things. But you can even get your dogs or your cats or your kids' faces put on these markers if you wanted to. They get crazy on there.
How much do they usually cost?
They can run anywhere from $20 for a set to $50. Depends on how cheap you want to go. Huh? It has to show up. You can make your own. I've known techs that make their own. So, but it has to show up. So if you get really creative, Benny, Crafter back there. So legal requirements mandate that these markers be present, right? You need to be using them. They're also like little makeshift left and right lead markers that a lot of hospitals have. If you don't have your markers yet, you can put those on there. It's just a little sticky. Annotation on digital images after image acquisition is not recommended due to high error potential. I don't know how many times I've been working with somebody and we're doing a lot of images and I'm just out there taking the pictures and they're annotating everything in the back. They see my marker isn't up there and we're just moving through fast like I'm a trauma in the ER and they mismark something. I don't know how many times I've mismarked something, right? Because those electronic markers are very easy to get used to. It's one of those, it's great that it's there, but you shouldn't be using it all the time kind of thing, okay? So make sure you have your marker, make sure your marker's showing up on the images. Marker placement is important. We'll do a lot of that in the lab time. We did a little bit of it with people that have already gone through it. Basic marker conventions are left, right on all radiographs. The marker should never obscure anatomy. Now, that is the trickiest thing I think in X-ray is making sure your marker shows up, but it's not anything that's important. Now, I told everybody yesterday, if your marker shows up a little bit in the shoulder, that's fine. It's not in the x-ray, you're looking at the chest. You're not looking at the shoulder girdle, right? You don't want to put it too far in because you don't want to get it in the neck or the airway. I don't know why Siri keeps trying to talk to me. The marker should always be placed in the exposure field on the edge of the collimation border, right? I showed you a little bit about that yesterday, and today I'll get to the rest of you on Wednesday. And a left and right should be used with CR and DR imaging. Also, don't throw it in the middle of a lead shield. Your marker will not show up in the lead. The image recorded by any exposing it, the image receptor to the X-ray is called a radiograph. You guys all know that, or an X-ray. Each procedural step must be accurate to ensure the maximum amount of recorded image information. The information obtained by the radiographic procedure shows the presence of or absence of abnormalities or traumas. Okay? So you're assisting in the diagnosis and treating of the patient. Without us, a lot of physicians would just be guessing. Think about that. Without us, a lot of these physicians would just be guessing on patient diagnosis. They need X-ray. We are a very important, vital part of health. A radiographer must evaluate each radiograph to determine the acceptability of the image featured, proper radiation safety practices, whether the objectives for the performing the procedure have been met. Okay, so there's a criteria for everything. We're going to jump right into the chest criteria. Do you have the top of the lungs? Do you have the bottom of the lungs? Did the patient take a big enough exposure, or inspiration, right? Is there any motion that you can control? Did the patient turn on you midstream? You know, is the patient lateral for a lateral view? Each projection has their own criteria they have to meet, right? Then you also have to take into the factors of the image itself. Is it a good image? Should I present this to the doctor? Will they be able to read it? Can they see lung markings? Can they see ribs, right? Can they see the heart properly? Additional image evaluation criteria to be considered includes the presence of patient identification, right? Did the proper patient name show up on that digital image? Is your marker there? Did you collimate? Is there evidence that you shielded? Did the shield show up in the bottom of the angles of the lungs because the shield was too high? Absence of artifact. Oh, did you forget to take that pretty necklace off of the lady? She's still wearing a bra. Did grandma wear her pretty sequin top and now you got a hummingbird in the middle of your chest? Properly dressing your patient is very important. Image evaluation requires an understanding of the anatomy, the image geometry, image display characters, and the image appearance of the pathology. Which pathology is down the road, but it's one of my big loves because I love seeing what's going on inside of somebody. So, an image display, we touched on a little bit of this. I hope I didn't confuse my first lab. Everything is in anatomical position, right? Except for most of your extremities. When you're displaying an image, okay? So a lot of times a hand is up. Anatomical position, a hand is down, right? The hand is up. When you're looking at an X-ray, okay, this is maybe an upright abdomen. It's not a full KUB because we didn't get down to the pubic symphysis. Marker's down here. I wouldn't have placed the marker down here. I would place it up here, out of the anatomy, because you're looking at the abdomen. But you're looking at this image. This is a hanging protocol, right? Hanging protocol applies on a computer screen as well. This is marked as the patient's right. If I'm standing here looking at it, what side is on the patient's right? My left. So you got to start flip-flopping your thinking a little bit, okay? The patient's left is on my right. So especially when you're putting your markers up on the board or on a patient, you have to think some of us that are directionally challenged, like myself. It's viewed from the perspective of the tube with the distal ends towards the ceiling. I'm going to repeat that one more time. It's viewed from the perspective of the tube with the distal ends towards the ceiling. Okay? So everything is displayed in anatomical position except for hands, wrists, feet, knees. Sorry, feet, toes. Okay? And for some reason, I don't know why, elbows just throw me off whether they're up or down. To this day. Image ID. Every image should have, see all this up in the corner? It's magnified down here. So it needs a date, it needs a patient name, or their medical record number, right or left markers, and the institution identification. Many ways to imprint ID on the radiograph. Digitally, that's all pretty much preset for you, as long as you choose the correct patient. Okay, pop quiz. All the following are required ID on a X-ray except the, who said C? Very good. C, preferred physician's name. You don't need that. Working effectively with obese patients. Here you go. Research shows that obesity has doubled in the last 15 years. 71% of Americans are overweight, obese, or morbidly obese, and there is a difference between all of those three things. Obesity is defined as an increase in body weight by an excessive accumulation of fat. The standard practice is measured by the BMI. If you're 30 to 39.9 is obese, and over 40 is morbidly obese, and your BMI is at those numbers. Body diameter and weight are both determinants on whether a X-ray can be performed. When you're talking about CT or MRI, there's only so much space in those round gantries. So if the patient is too large, they just won't fit. Even if the table weight will take their weight, they just won't fit. Oh, I jumped to a new question here. A technique chart must include all the following except, very good, pathology type. That jump, sorry.
It's got out of order.
It did.
It was right after the other one, and we got numbers for some reason.
I wonder if I did something last night. Sorry, guys. Equipment consideration. Every table has a weight limit. The longer I've been in this field, the weight limit has just been steadily going up and up and up. Now, if it's a surfboard type of table, their weight limits tend to be less. That is a tabletop floating type. The same is back in your lab. It tends to carry a little bit more weight. I would say the average weight limit is maybe 500. Older machines, it might be 300 to 400. Yes, ma'am.
There's tables for those on page 40.
Okay.
Just FYI.
Some procedure tables are going up to as high as 700 pounds to take it. Like I said, there are a specific diameter limit for CT and MRI. Without appropriate equipment, patients weighing more than 350, 450 pounds cannot be imaged in some cases. I have had 600-pound patients that we just cannot diagnostically give them any quality images. The closest we would come is a chest x-ray, portable chest x-ray. And I'll get to the next slide because I wish I would have known this on some of my patients. So, sorry, we're going over, guys. I got 6 more slides. Can you hang with me? I'm doing fast. There's immobile device, or there's transportation devices. There's big lifts. The bottom picture is a big Hoyer lift. Some ERs use these floating, like raft-looking devices to move obese patients. I know some EMS workers, these are equipped to move a patient out of their home into an ambulance. Some things to really consider, this is very important, is communication, is just communicate the procedures to the patient, tell them that you're going to try and get the best images possible. Be empathetic. don't mention their weight. You can politely ask what their weight is if you think that they might be at the max for the table limit. You can also start with the resource of the nurse, because a lot of times they'll take a weight on the patient. Ask the nurse first. The nurse is like, I don't know. Patient comes down, you're doing abdomen x-ray, you're just worried that they're just going to be too large. You start to see people, right? You start to see, and you can kind of gauge people a little bit. You just ask, hey, I just have to ask you, what's your last known weight? We're going to get you on this x-ray table for an abdomen picture. I just want to make sure we're using the proper room, right? Just try to be as empathetic as possible.
So what if they are over the limit, then it's just.
So if they're over the limit, and if you don't feel comfortable, find your tech and go discreetly tell your tech out somewhere else, say, this patient says they're this heavy, this room says it's this much, what do I do? And then hopefully the tech will come in and be like, I'm sorry, we're gonna have to get you another room, maybe, or we're gonna have to call your nurse, I don't think we can do this particular image right now, okay? And sometimes patients will surprise you at how mobile they can be, even at a larger weight. They might be able to stand up for that chest x-ray. It might surprise you. Okay, so just talk to your patient. Ask them what they're capable of doing. Explain to personnel before time, if you've got to move a patient over that's very large, get as many hands as possible, move the patient safely, right? Explain to the patient what you're going to do. When a patient is that large and if they've been bedbound, they're very anxious about somebody pulling them over. Even if it's a lot of people in the room pulling them over, they're still very anxious. These challenges exist. This is the key I wanted to tell you. Okay, everybody find your jugular notch. Right? Okay, if I would have known this, I would not have been guessing at some of my obese patients when positioning for them. So from the jugular notch, you can go down and find how far the pubic symphysis should be, no matter how much extra is here. Yeah, if you look at the bottom there, look at those numbers. So if the patient is that high,
I don't see the numbers.
yeah.
So sorry.
So 6 foot, say 6 foot, 500 pounds, from the jugular notch, 24 inches down would be their pubic symphysis. Because you can get a lot of extra tissue and it's going one way or the other sometimes, and you're like, this doesn't look right, right? It doesn't look like the normal body. So if I would have known this a long time ago, it would have taken a lot of guesswork out. And you can still find, like you can find on most people the sternum, you can find the jugular notch, right? You're not going to be feeling for that crest on somebody that's 450 pounds. You're just not, okay? But these are the things that you can find. Okay. Which of the following will affect whether x-ray can be performed on an obese patient? Weight, yes. Which guideline is used to locate the pubic symphysis on an obese patient who is approximately 5 foot 5 inches tall? It's C, 22 inches. And it's C. Why is that in there twice? And then I just love this meme. Don't call me an x-ray technician. We are not technicians. I had it, and admittingly, actually got really nasty with me when I said, oh, you're an x-ray technician. I said, no, I'm a technologist. I don't fix the machines. I use the machines.
I had a girl at work say, are technologists more educated than technicians? I was like,
Nope. Different
well,
job titles.
she's actually pre-med, like she's more medical.